Excellent. Good morning, everybody. I'm Helen Dent. I'm Chief Executive of BIVDA, the British In Vitro Diagnostics Association. So I'd like to welcome you all to our webinar this morning to talk about the NHS 10-year plan that came out yesterday and how it will affect the diagnostics industry. Chairing our panel today is BIVDA Ambassador Maggie Throup, former Health Minister and qualified biomedical scientist. And joining her is Bernie Croal, chemical pathologist and president of the Royal College of Pathologists. Paul Fisher is our Director of Policy and Programmes and former civil service, and there's me, of course, as well. Ben Kemp is also on hand, who will be supporting this webinar as we go through. We will have about 10 minutes at the end of the webinar for the panel to answer any questions that you might have. So please add those questions to the chat and Ben will pass as many as he can onto the panel. So after that introduction, I would like to hand over and welcome and thank you very much, Maggie. Over to you.
Thank you, Helen, and thank you for organising this webinar on such an important topic. It's fully recognised that pumping more and more money into the NHS isn't the way forward. That's been tried, and so we know it's not working. And the NHS cannot continue to grow in the way the current model promotes. The NHS 10-year plan seeks to address what has become a service that, despite hard-working and motivated staff, is not delivering what a 21st century population needs. The three shifts in the plan that have been widely publicised remain the basis for the plan, and specifically this is from sickness to prevention, from hospital to community, and the move from analogue to digital. There are changes across the NHS from structures to systems, and there'll be devolution at the ICB level and neighbourhood teams in conjunction with local authorities as healthcare moves to from the hospital to the community. And partnerships will be critical to deliver this world-leading healthcare ambition. There are 5 big focuses around life sciences as I see it. First of all, data collection for healthcare impact, led through Health Data Research UK. Secondly, AI to drive patient health and productivity with a new regulatory infrastructure. Thirdly, genomics and predictive analytics and a personalised care journey from birth. Fourthly, healthcare in real time with an increase in healthcare wearables. And fifthly, robotic support, automatic processes for improving productivity and efficiency. In fact, from the life sciences point of view, last night on Newsnight, the Secretary of State, Wes Streeting, said that 10 years ahead, the most exciting thing happening as a result of the 10-year plan will be the revolution in life sciences and medtech. I'm sure that's music to everybody's ears that's on this call today. So going back to the plan, it outlines innovation zones to generate evidence for innovation, adoption and spread. Clinical trials being completed in under 150 days, monitored through scorecards. The plan has a big focus on data, digital and AI, especially for AI diagnostic tools and AI health warning systems, to the extent that if AI fails, I think then the plan will fail as well. So there's a big commitment to better health data, including from screening for predictive and preventive healthcare. The My Health tool will hold patients and the public's data in one place, with a commitment to a new health data research service for better use of health data. Some aspects of the plan are already in place. For example, the health incentive scheme in Wolverhampton using wearables has been in place since 2022, and it's something that I was rolling out when I was health minister. And also the neighbourhood units, we've got them in quite a number of places across the UK, and you could also say that community diagnostic centres are a start of that to roll out on a bigger scale. But these need to be rolled out at scale and also more joined up, and the use of best practice. The plan is very high level, it's aspirational and undoubtedly identifies problems and proposes solutions. But to me, the biggest unanswered question is, how is it going to be delivered? And this is a significant omission, and I really would like to know if the government do have a delivery plan that sits underneath it. Because without this final piece of the jigsaw, will its aspiration and vision be really realised? I'm going to now hand over to Bernie for his perspective as President for the Royal College of Pathologists. Thanks.
Thanks very much, Maggie. I mean, I think I agree with all those points that you've made. There is a lot of uncertainty with the plan. Certainly, as a Royal College, we were not heavily involved in the plan at all. Neither were any of the other Royal Colleges. Indeed, it was emphasised that this is not a plan that was designed by the NHS or even by NHSE or DH. It was a plan that was primarily ministerially led and constructed. That said, I think there's general agreement that the direction of travel that the plan paints out is one that we could agree with, and certainly the concept of moving care away from hospitals to the community, empowering patients more in their own health, and using more tech for the whole areas of processing, communication, and the admin side of the NHS seems very sensible. But as you said, Maggie, there is no implementation plan. I mean, they've even admitted that at government level, and there is no extra money. So in many ways, it's not a plan for today; it's a plan for tomorrow, and we need to try and ensure that we can jump on the bandwagon of the momentum that this plan hopefully will create, and ensure that pathology in particular has a strong voice there. They make a strong point as well around the first step is going to be about fixing the basics, and there's a lot of basics to fix. And I think with regards to pathology, we all know that pathology has expanded, but our capacity and workforce has not. So that, to me, are the main basics that we have to focus on. Clearly, our IT systems, our LIMS, our order comms have been left way behind, and we have to also ensure that they get up to speed so that they can become part of the plan, especially with regards to integration with the proposed single EPR and the new NHS app. At the moment, we're very much outside the room, and I think we need to use that as an opportunity to help promote the bits of work that are ongoing at the moment around adoption and creation of SNOMED CT and FHIR concepts that will be needed in order to link in with all those other systems. I think there's a balance that we need to look at of trying to forward the aims of the plan versus the challenges of service collapse, which we know is happening at the moment across the UK, patchy, but it's still a huge risk. And I think we need to ensure that pathology is able to make a strong case and be part of the challenge and the bun fight that inevitably will go on in terms of trying to get a slice of the limited amount of money that is out there. It's been emphasised that this isn't about extra money, it's about using the money that's already there. And I think we're going to see a bit more flexibility in the NHS budget. There will be losers as well as winners, of course, and we need to be sure we're on the latter side of that. So overall, I think, it's a great plan, it's a great vision, it's where we want to go, but with no implementation plan and no money, the onus is on us to create that momentum, demonstrate the importance of what we do, and at the same time, by hooking everything we need in pathology to the objectives of the plan, we have that opportunity to open the doors. And at the moment, those doors are quite firmly shut. So we need to really go for that. Industry, private sector are important in this, not just to join up with pathology services and create that stronger voice, but perhaps even to share pump prime investment to get us over that startup line and demonstrate the value in what we do. Thank you.
Thanks, Bernie. That's really helpful. I think I'm going to start with a question for each of our panel. Well, I'd like your perspective for the first question. So what are the biggest changes the plan introduces for diagnostic service in delivery? And I think you probably each come to it from a different angle. I'm going to start with Helen, if that's okay.
Yeah, so The thing that I have noticed all the way through this and also through the development of the plan, the biggest change for me is very high level, and it's like the change in attitude and the change across the system that people want this to happen. Now, I've never seen this before to this extent, with the number of people on the same page and the number of opportunities that if everybody does work together, like Bernie said, that I just think that things will be delivered, and that is the implementation that Bernie was mentioning previously. I've just not seen the attitude behind something like this before be so aligned.
Great, thanks. Paul?
I think it's really interesting because there's a number of areas that are pulled out of this plan in a way that haven't been pulled out before. The move to neighbourhood treatment centres and the move from sickness to prevention and the focus on people taking better care of their own health and lifestyle. Well, if that doesn't say diagnostics, I don't know what does. And I wonder whether there's a question for the industry as to whether we need to start looking at how our tech can be adapted, one, to be more user friendly. So it can be used as you know, what we'd call in the army squaddy proof. So it can be as close to the end user as possible and is used as efficiently as possible. But also so that it can be placed outside of those traditional lab-based treatment centres. And that's something I know you're going to ask Bernie about in a bit, so I'll leave it there. But also I think the really interesting thing for me for diagnostics is just the amount of wins that I think we've got here in relation to medicines. So I think probably the pharma industry are feeling slightly uncomfortable, but with a real focus on genomics, a real focus on point of care testing, neighbourhood testing, and a real focus on wearable technology for screening and devices, I think there are real opportunities for the industry here. And the challenge that we've got at BIVDA, I think, is to make sure that as the basics are fixed, as Bernie articulated earlier, that we're still coming that kind of innovation pipeline of products that will be able to be fit to serve the future NHS. What the NHS needs now for this plan is not what the NHS will need in 5 years, not what it will need in 10 years. And we as an industry need to make sure we reflect that.
Thanks. Bernie, do you want to add anything to that?
Yeah, I think to me, sorry, there's an ambulance rushing past. I think for me, the emphasis of this plan is about trying to rescue the failing health service, and in doing so, to try and create more activity, more patient care, and all of that will inevitably increase the demand for pathology services. So I think we need to be, clear that there is going to be a future need for more pathology, whatever form that takes. And I think, industry needs to embrace that. In terms of the technical aspects around things like point of care and other novel wearables and so on, I think what's most important there is that we introduce those kind of concepts, not just because we can, but because they're worth it. So I think we really need to ensure that whenever there's an opportunity to do these things in the community, that we do them for the right reason. For me, the expansion is going to be not about point of care particularly, but about a bigger expansion in community sampling, which will then be transported to central labs. That, I think, is where the growth area will be from that spread out. I say that because point of care is nice and trendy and everything else. It's expensive, and I think we need to be very, very minded to ensure that there's value for money there.
That's a really, really good point, which something that really hasn't been touched on too much. The next question I'm going to actually target at Paul. So the two key areas that BIVDA members find challenging are regulation and market access. How does the plan look to resolve these two issues?
Absolutely. So I think there's good news and there's bad news here. So I'll do the easy one first. So market access, there's some really positive steps in the plan that I absolutely really welcome. So first of all is what they're calling the innovation pathway, innovation compass, which is a really badly phrased way of saying that the NHS is seen as a single entity, and it isn't. Our members constantly complain about having to have multiple points of contact before they can get a product adopted and sold across the NHS. And the innovation passport looks to address that by ensuring that once a product is approved, there is a single pathway into the NHS, and then there's universal adoption across the various entities. I think that's great news. They talk, and this goes back to your point earlier around, the devil really is in the delivery. They talk about a streamlined procurement landscape. Brilliant, but I'd like to know what that is. I'd like to know exactly how that's going to look. And there's also a call out really early on in the executive summary about how they want to work more closely with industry to streamline these areas. So I really would like to see Alan Milburn's missing chapter on how this is going to be achieved. But what is important is they've recognised the problem. If you had one criticism of this plan, it's very good at calling out the problems and solutions. It's not very good at calling out how those solutions will be delivered. But I think it's encouraging they've done that. The regulatory piece is really interesting. The Department of Business released their industrial strategy plan last week that talks about reducing regulatory burden on businesses by about 25%. We're not seeing that in reality. In fact, we're seeing the MHRA presumably likely to increase fees in the not too distant future. There's already been a small increase recently. And that's an area that BIVDA really do need to work with government to, one, fully understand. And ironically, Helen and I are seeing DBT this afternoon to talk this one through. And then secondly, to make sure that that 25% saving, if possible, is delivered to our members. There are other areas that are interesting. I mean, NICE and the MHRA are being tasked to work more closely together. NICE's remit is expanding to cover diagnostics to have a greater emphasis on diagnostics rather than simply medicines, as historically been the case. And I sort of idly wondered a while ago if the next catch in the bonfire of the Quangos might be the MHRA and NICE merging. We've not seen that in the plan, but it's interesting that relationship is going to be closer and more streamlined, based presumably on their innovative devices access pathway pilot, which they used quite recently. So again, I think good news, but I'd really like to see the substance behind the headline.
Next question really is going to be for Bernie. You've already sort of started to touch on this. So how will the shift to neighbourhood-focused health systems affect traditional laboratory-based testing and pathology networks? You've mentioned it already, but perhaps you could expand a bit on that.
Yeah, I mean, I think the overall message is that we will see an increased demand and an increased volume of testing coming the way of pathology labs. We know that the aims of the plan is to essentially try and improve access to healthcare and also reduce the waiting lists, and all of that activity will release pathology testing, and so we need to prepare for that. We need to look at clearly our capacity and our workforce, which will be required to deliver that kind of activity. So I think there's a real opportunity for pathology services to use that argument as a strong way of maybe securing a bigger slice of the funding that's out there, especially in the training, but also clearly in the investment in the tech that we need to make that happen. In terms of the split, as I said, between community-based testing versus community-based sampling, I think it depends on the systems that are being looked at. It will depend on the evidence, but I would hope, as I said before, that we assess them pragmatically and we ensure that we don't just implement on the basis of can it work or even does it work, but is it worth it is more important, because a lot of the time it isn't worth it, and we need to make sure that's part of the pathway. But I think there's room for everyone. I think there's also potential expansion with both home testing and home sampling, which again will empower patients to take a better control of their healthcare, and all of that ideally needs to be under laboratory oversight, if not control.
Sticking with you, Bernie, genomics are one of the 5 transformational technologies called out in the plan. What are your thoughts on this with regards to the laboratory and also with regards to the diagnostic industry? Yeah,
clearly genomics is a hugely expanding area, and again we have to be realistic and we have to be pragmatic about what we can practically do and what we can afford to do. We know at the moment that genomic services are really struggling in terms of being able to deliver the important information for cancer pathways, for example, and ensure that they can turn around results in a time frame that enables those important therapeutics to be implemented. And at the moment, patients are being failed. So we need to ensure that we don't expand too fast when the capacity is not there. But at the same time, making sure we've got the capacity in the future will be highly dependent on automation, on new tech coming into the labs, but most importantly, workforce, because training that scientific workforce in particular is under huge pressure at the moment, and we need to really do better in order to meet those challenges that are coming down the line.
Great. And my last question before we take the questions that hopefully have been posted by the audience, and this is probably one for Helen. So the plan is extremely high level, as already talked about, so we don't know how it's going to be delivered. But at this stage, how do you think that industry can best support the NHS and government to ensure that the plan is a success?
Yeah, it is high level, and there is a lot of experience within industry about how to deliver things. It's something that people should actually take advantage of and take that experience. I do think, and I think it was you, Maggie, that touched on it a little bit earlier, that oh no, it wasn't, it was Bernie actually, about making sure that things are provided because they are needed rather than because things are done. And I think we as a trade association and also our members need to be aware of just because you can doesn't mean to say you should. And I think if we can start looking at that and also start to provide evidence of successful things that we have all done in the past, over the past 10 years particularly, then we can start to get some of these things over the line, because the difference here, like I mentioned on your previous question, is the attitude, and people are wanting to listen to us, and that trust is actually increasing. But we don't need to we need to actually capture that and use it with our evidence, as opposed to just going out and potentially thinking of where can we sell more things.
Great. Ben, do you want to fire the first question and work out who's best to answer it?
Absolutely, very happy to. Thank you very much, everybody, for submitting your questions. I think the first one we're going to look at is the missing chapter, the chapter 9 that was meant to be written by Alan Milburn. And someone's wondering if we're anticipating a 2 or 5 year delivery plan with accountability and clear funded milestones. I don't know if anyone wants to.
I think my initial comment is that the 5 year funding is meant to be going ahead. But Paul, did you put your hand up to?
No, sorry. But happy to support. I mean, hoping, if not anticipating. Certainly think back to my days as a senior civil servant. The biggest challenge that I had with 1 year funding settlements, it's impossible to think strategically when you are only funded for a year at a time. The mood music is very much in that direction, Ross, but it's whether or not that they have the commitment to deliver behind it. I would certainly hope for that, and I can't see how you deliver it in any other fashion.
Yeah, I think it is such a big change that it can't be done year by year. There's got
Absolutely.
to be some sort of plan, but as you say, until we know delivery, it's very hard to know. But once again, it's perhaps the voices of the industry that can help to, and obviously people like Bernie can help to influence that, to make sure that that the funding is there at the right time, because it may the quantity, if you divide the 10-year budget by 10, it probably isn't appropriate to do it year by year. You probably need to front load it. Any other comments, or back to Ben?
Nope. Perfect. Well, the next one's quite popular. This is regarding the amount of quangos and regional organisations that are in the UK that aren't necessarily all coordinated. Do we need to rationalise these for better efficiency and alignment to an NHS plan?
Helen, you were quick to take that.
Yeah, but I'm not going to actually directly answer the question. Essentially, we also have the industrial strategy and the life science sector plan that was originally intended to all be released together and to be read together. There are challenges with that life science sector plan as well, but some of the things that are more system-wide and more future direction will be addressed in that life science sector plan along with the industrial strategy. And going back to a previous point, the 10-year plan is about fixing the basics now. So they are two distinct different plans. From our understanding and from our involvement in developing the life science sector plan, those sorts of things about there's another question in there as well about the future of SMEs and quangos and alignment and how the system works together. I think we are more likely to be seeing those in the other plan, which is due in a couple of weeks, as opposed to the detail of the 10-year plan.
Next question, Ben.
Perfect. So slightly going on from what Helen was just saying there, how will the 10-year plan better support the British SME diagnostics industry, which currently struggle with time to uptake? And how might it help the funding of NHS evaluations, as currently these costs all fall to SMEs to fund?
Bernie, was that a hand up?
Yeah, thanks. I think the plan has opened the door. I think that it clearly recognises the frustration, the barriers and the red tape that exists with identifying new products in particular, trialling them within the healthcare market, and then getting implementation. And we know about the huge delays we see in even exceptionally good tests such as natriuretic peptides. They took far too long to be implemented. Even now, they're not universally out there. So we need to use this as an opportunity, really, to ensure that those bits of red tape are taken away as much as we can. So I think the onus will be on both the pathology profession and industry to work together to better ensure that that sort of roadmap can fully be implemented, so that we can take new products, assess them properly, and then look at implementation. One final point, though, I think we need to do better in the area of that begins right at the start. I think the pathology profession needs to work closer with industry to identify what the need is for products, rather than wait until the product's there and try and find a use for them. So I think there's a lot of joined up work that we can do with industry, both at the sort of design stage, but also at the testing and implementation stage. Inevitably, there's still going to be a lot of red tape around, budgets within service providers that are inflexible. So we need to work harder at demonstrating the overall value to the NHS, not just the cost implications for the laboratory budgets. Thanks.
Thank you, Bernie. Very, very insightful. Paul, did you want to add to that?
I strongly agree with everything Bernie said. I think the other thing to focus on is the detail of this will come in the life science sector plan, which is currently held up with wrangling over VPAG, the medicines pricing agreement system. And it's a shame they've not been released in lockstep, because I think it would have answered some of the questions that we've got. It's slightly more tactical than this one, but we absolutely recognise that, and that's a key part of our advocacy. And I think the point that Bernie makes really clearly is the more we know what the NHS's unmet clinical needs are, the better industry can serve them. We've got the creativity and the ability to deliver them, but what we shouldn't be going is, we've got this wonderful thing. We should be going to pathology networks, providers, and saying, what do you really need? If you could wave your magic wand, what would you want in your diagnostic box tomorrow? And we've got the ability, the industry, got the ability to deliver that. So I think that closer relationship is crucial. And I think the move to value-based procurement that the NHS are talking about, that the plan talks about, is particularly powerful, because diagnostics will always add cost and complexity to a pathway, but in doing so, they add value. And that's the important thing that people need to recognise.
Helen, your hand went up.
Yeah, it was just to very briefly add to that, is that we do need to recognise, NHS side, government and industry, that moving forwards, we really do need to have that communication and that understanding of what the NHS need is. But we're also in a position where we haven't got that for the past 10 years. So therefore, we need to look at what can we do. And I think Paul said this early on, what can we do with what we've got? Because the worst thing we can do is wait for something better to come along, when there are things that are around that we can use that can move the dial somewhat while we're moving forwards to this new way of working more collaboratively and adoption in the NHS. Because otherwise we're just going to be waiting for the whole process to progress. And what we really want to do is look and say, what can we do now? How can we do that? And then have those communications moving forward.
That's great. Now, sadly, we've hit 11 o'clock. Doesn't time fly when you're having fun? But I think what the plan does is create opportunities. I think it's up to people like Bernie and organisations like BIVDA to grab those opportunities. And even though we don't know, there's still lots of questions that aren't answered. Perhaps almost we need to answer those questions ourselves as a body, so we can actually move forward and shape the future of the NHS the way that the people who've got so much in-depth knowledge think how it should work in the future. So I'm sure it's just the first of many discussions that BIVDA are going to be hosting on the 10-year plan. And I think the more we find out about it and the life sciences strategy, then the more can pull the pieces together. So I want to thank everybody for joining. I hope you found it interesting. We could probably talk all day about it, but sadly, I'm sure we've all got other things to do. So I'd like to thank Bernie, Paul and Helen for your insights, and once again, thank everybody for joining. Thank you.
And I'd like to thank you, Maggie. Thank you so much. Thank you, Bernie. Take care, everybody. Have a good day.
Thank you.
Thanks, everybody.
Bye-bye.